Hi, and thank you for joining my presentation today. I'm going to be going through airway emergencies, and here are the objectives of our presentation. First, we're going to go through a series of cases that are going to present scenarios of airway emergencies. Now, it's important to remember that when we talk about airway emergencies, we're not only focusing or fixating on difficult intubations. Difficult intubations are one component of airway emergencies, but airway emergencies can be really more vague and can involve a lot of different aspects of the airway. So we're going to talk about cricothyroidotomies. We're going to navigate on how to manage a patient with tracheal stenosis, and we're going to end on how to save a patient who comes to you with hemoptysis. Now, case number one is a patient who is a 30-year-old coming in for a right knee arthroscopy. Patient is 75 inches, 180 pounds, has a history of moderate asthma, and note that patient's wheezing in the pre-op area, is on albuterol, PRN, has no allergies, is a smoker, and has stable vital signs. Your plan for an anesthetic here is an LMA 5, and you will plan on maintaining this anesthetic with sevoflurane. Intra-op, your capnography changes, and you hear a high-pitched inspiratory stridor, and the stridor then changes into silence, and you, as the anesthesiologist, are now faced with the scenario of trying to identify what is going on with the patient. Let's say if you had a bronchoscopy in the room, you go in through that LMA, this is what you will see. And here is a image of a laryngospasm where the vocal cords are in a laryngospasm. And this is a reflex closure of the vocal cords secondary to a nauseous stimuli, or if your depth of anesthetic is decreased and your patient has an LMA in place, sometimes the laryngospasm can be triggered in that scenario. How do you manage laryngospasm? Positive pressure ventilation is recommended, increasing your depth of anesthesia. And in specific scenarios where you have complete closure of the cords, you may want to think about increasing your depth of anesthesia through your IV anesthetics and not your inhaled anesthetics. Interrupt the initial stimulation. So if the surgeon is continuing to operate, you would tell them to stop the stimulation. And meanwhile, to buy yourself some time, you can give a small dose of 0.1 milligram per kilo of succinylcholine, and that will buy you some time to basically deliver your positive pressure and to deepen your anesthetic. And if all else fails, you can give an intubating dose of sux or intubating dose of non-depolarizing muscle relaxant and perform tracheal intubation. Now, let's say we solve the problem, and on emergence, your patient now is in stage 2, and again, you hear another round of inspiratory stridors, again, silence, and then desaturation. So you presume that there was another episode of laryngospasm here. The next thing you see is frothy pink secretions coming out. So in this scenario, the laryngospasm led to a negative pressure pulmonary edema in your young, healthy, powerful muscular patient, which is basically the forceful inspiratory effort in the setting of an upper airway obstruction. In this case, the upper airway obstruction is your closed glottis. Therefore, you created a scenario where you have subatmospheric alveolar pressures that led to transudation of fluid from your pulmonary capillaries into the interstitial space, and that is what you see with the pink frothy secretions coming out of the patient's tube. This is a non-cardiogenic pulmonary edema, and the way you manage this is to, first of all, relieve the obstruction, provide oxygen to the patient, and manage the pulmonary edema with diuretics, opioids, and in some scenarios, you may want to even consider mechanical ventilation over a period of time. Now here we move to another case where we have a 45-year-old lady coming in for lap hysterectomy. She's 65 inches, 160 pounds, diabetic, hypertensive, asthmatic, has a straightforward surgical history, takes metoprolol, simvastatin, has allergies to penicillin, she doesn't smoke, she doesn't drink, and has normal hemodynamic numbers. You decide to induce this patient with IV anesthetics, midazolam, fentanyl, propofol, and you give 100 milligrams of rocuronium. You perform laryngoscopy and you intubate a very straightforward airway. However, upon intubation, you think you're 100% sure that you are in the trachea, but yet you don't really see any CO2 on capnography. Being very confident that you are in the airway, and you deepen the anesthetic, and you will notice that your capnography looks something like a severe obstruction. And here, I'd like to point out the first waveform shows a normal capnography. The second waveform shows a moderately obstructed capnography. And the third waveform is a waveform of which looks like a shark fin, and this indicates severe obstruction. And I'd like to pause and say that if you, in this case, diagnose bronchospasm, every time you intubate the airway and you don't see CO2, there are multiple things that could have happened. Obviously, it could be that you were intubated the esophagus. So never make the assumption that the patient is having bronchospasm, especially in patients who have history of asthma and so on, and you anticipate a bronchospasm. It could still be that your tube went into the esophagus. So really double check with the bronchoscope, or redo the laryngoscopy. Do not make assumptions. Number two, your patient may be in cardiac arrest, and that can be another reason why you may lose your CO2. And number three, you may have severe bronchospasm, that sometimes the bronchospasm is so severe that you may have a transient episode of losing your capnography. But usually the capnography should come back. And in this scenario, it is the third waveform that you notice on your anesthesia machine, which indicates severe obstruction. How do you manage this? You deepen the anesthetic. I would definitely recommend inhaled anesthetics with sevoflurane and not desflurane or isoflurane that could be irritating to the airway. Albuterol, small doses of epinephrine can also help relieve the bronchospasm. Now, in the same case, you intubate, you resolve the bronchospasm, and intra-op, now the surgeon's performing the laparoscopic hysterectomy, and they ask you to place the patient in Trendelenburg. 5 minutes later, you notice that the patient's saturation now drops to 85%. Your peak inspiratory pressures are now from 35 to 46 millimeters of mercury. So what do you think is happening here? You change the position of the bed, patient started desaturating. What do you think is the most likely scenario? So in the setting of placing the patient in Trendelenburg, and especially when you have a patient who has a pneumoperitoneum, you will have cephalad migration of your carina. So when your carina migrates cephalad, that means your endotracheal tube is now going to become an endobronchial tube. That means you will be main stemmed into the right or the left side. And therefore, now you have a patient who is getting one lung ventilation, which is leading to a desaturation event. So every single time you change the position of the bed, or even when you change the position of the head and you have a desaturation event, always be mindful about checking your tube positioning and readjusting in case the patient was main stem. And again, note that if you flex the patient's head, you will have a caudal movement of your tube. If you extend the patient's head, the tube will move cephalad. And a lot of times in ENT cases, or any case that involves, the upper portion of the body, the surgeons may move the patient around, and you want to be mindful about where your tube is going in these scenarios. Now, you fix the problem, patient saturation gets better, then you notice that there are further increases in the peak inspiratory pressures again. So now you troubleshoot the problem. Now seems like you have another problem. So what are other reasons that lead to increase in peak inspiratory pressures? Secretions. So you can, go in and suction out secretions. That could really lead to increased inspiratory pressures. Kinking of the tube. Patient can be biting on the tube, even though you should always have a bite plug, but that could also always happen. Bronchospasm. And there are also scenarios that lead to decreased lung compliance, especially in the patient having laparoscopic surgery. It could be the insufflation that's leading to decreased compliance due to atelectasis and so on. It could be pneumothorax. It could be that the diaphragm is now really pressing on the lungs and causing decreased compliance. It could be an asthma exacerbation. So the differential is quite long, and it's important to really work towards one of these scenarios in order to understand why your patient saturation drops. Now, in the same case, your SATs drop again to 93%, and your end-tidal CO2 is stable. What do you think can lead to hypoxia? Could be a probe malfunction. Could be that your circuit is disconnected. Could be that your patient has low FRC atelectasis, again, like we talked about earlier. If you have a patient who is in Trendelenburg position and they have a pneumoperitoneum, that's going to lead to atelectasis. So if you don't have an appropriate amount of PEEP, that patient is going to be prone to atelectasis. And over time, that could lead to hypoxia. It could be decreased cardiac output, can also lead to hypoxia. It could be right to left shunting. But the idea is to always understand why the patient saturation dropped. And meanwhile, turn up your oxygen to 100%, confirm that you are delivering 100% of FiO2, and confirm that you're ventilating by assessing your end-tidal CO2. Hand ventilate to basically feel and assess for the compliance. And you can also detect the compliance number on most anesthesia machines. You will have that number noted. So be aware of where your compliance was and where your compliance is at the moment. And confirm bilateral breath sounds. Check your peak inspiratory pressures, your blood pressure, your pulse, your tube position. It's multiple layers of parallel processes that you have to perform at the same time in order to really understand the reason why the patient became hypoxic. And you can further along add data to your observations by getting an ABG, doing a bronchoscopy, and getting an EKG, chest x-ray, transthoracic echo, and so on, because the etiology will lead to changes in any of these studies. For example, if the patient's having a cardiac event, on the transthoracic echo or on your EKG, you may notice ST changes or wall motion abnormalities. Therefore, you can think about hypoxia in terms of two different categories. Hypoxia that is due to a primary airway breathing issue, for example, hyperventilation, means intubation, unoptimized vent settings, lack of PEEP or too much PEEP, bronchospasm, aspiration, pneumothorax, pulmonary edema. Or you can have hypoxia that is not related to problems with ventilation, but it is linked to anaphylaxis, pulmonary embolism, or coronary event, or sepsis. Therefore, all of these will have various branches of how you manage the patient to save them from the hypoxemic event. Now we move on to a third case where we have a patient coming in for EGD and a dilation. The patient is 69 inches, 139 pounds, with a history of esophageal cancer, status post-esophagectomy. And the idea here is to perform an EGD and a dilation. You induce the patient, but prior to induction, you give the patient 30 mLs of sodium citrate and a milligram of Versed. And you perform IV induction with an RSI, propofol, remifenil, and succinylcholine. You place your patient gets laryngoscopies in the proper position. There is a cricoid pressure with 30 newtons of pressure applied to the cricoid, and upon laryngoscopy, your resident notices that there's bilious output in the oropharynx. They intubate the patient with a 7.5 intertracheal tube, and what do you think happened here? Therefore, this is a very clear example of a pulmonary aspiration. If you ever have an aspiration event, first of all, you have to be aware of the patients who are at risk of aspiration and perform proper induction on these patients. And if the aspiration does happen, you want to intubate the trachea and start suctioning the secretions as fast as you can, because complications that can arise from aspiration are things like bronchospasm, pneumonitis, pneumonia, ARDS, lung abscesses, empyema, and the mortality can be very, very high, up to 5%, even more in a lot of these very frail patients. The risk factors of aspiration are any patient with extremes of age, very old patients, very young patients, emergency cases, any case that involves the esophagus or the abdomen, patient who is a full stomach, and patients who have delayed gastric emptying because of diabetes or gastric outlet obstruction, patients who are on certain types of medications like opioids and anticholinergics, pregnant patients, patients in pain, patients with decreased depressed level of consciousness, patients who have had bariatric procedures, patients with difficult airways, patients with neuromuscular disease, or any patient with esophageal pathology. It is important to identify your patient as being high risk and to empty the stomach if you can prior to inducing these patients. For example, if a patient comes in with bowel obstruction, you never want to induce those patients prior to placing a gastric tube. And if you do have a gastric tube in place, make sure to decompress the tube that's inside. That also includes tubes such as PEG tubes. We can have 3 different types of aspirates. It could be acidic, non-acidic, particulate, and the patient will eventually develop, after an aspiration event, hypoxemia, fever, tachypnea, rales, cough, pneumonia, signs of pneumonia on their chest x-ray. To manage them, like we said, the most important thing is to bronch and suction out as much as you can once the aspiration event happens, to intubate the patient and to do mechanical ventilation with PEEP. Antibiotics are only indicated if there's any suspicion of a gram-negative or anaerobic infection. Now we move on to our 4th case of a 57-year-old patient coming in for VATS wedge resection, 65 inches, 127 pounds, with an airway exam that is not very reassuring. Mount fatty tooth, 3 finger breadths, intact teeth, free neck range of motion, but you know, the case goes well. You intubate the patient. There are no issues, but upon emergence, this patient's not pulling good tidal volumes. You have tidal volumes of 200 mLs with 15 millimeters of pressure support. So what are the reasons that could lead to this? On emergence, if you have decreased respiratory function, it's either because the patient has decreased respiratory function to begin with, or because you had the patient go through a major pulmonary resection and now their minute ventilation is not adequate, or it could be as simple as residual muscle paralysis. Therefore, no matter what kind of case you perform, always make sure that at the end of the case, your patient will be fully reversed, and assess the residual blockade with a train of 4 that is more than 90%. And do not rely on assessing the patient's clinical status, such as like protruding the tongue, or if the patient's able to lift the opposite shoulder, or if the patient has normal tidal volumes, because these are unreliable clinical measures. The only reliable clinical test that could guarantee that or make it more likely that your patient's fully reversed are things like 5-second head lift, a steady hand grip, and a maximum inspiratory pressure of 40 to 50 centimeters of water. But the most reliable tool is to assess a quantitative twitch monitor. Now we move on to case number 5, and here is a 59-year-old patient with lymphadenopathy coming for cervical mediastinoscopy. This patient has a history of OSA, uses a CPAP, and upon exam in the pre-op area, you notice a very large neck circumference, Malpathy 3 finger breadths, and a few missing teeth. Now you're coming out of case number 4, you're feeling very confident that you can easily intubate this patient. So you don't really try to take the extra measures that you should take if you have a patient with those characteristics. So you perform your first laryngoscopy, you see MAC 3, grade 3. You perform your second laryngoscopy, now with a MAC 4 blade, you see grade 4 view. And now you have your colleague come over and they use a Miller 2 and they see no view. Now the patient's desaturating. So this is the scenario that initially you should try to avoid these situations by trying to really optimize your patient's positioning prior to intubating them. Because when you're doing your initial assessment, you have to evaluate the mouth opening, the jaw protrusion, the head extension, thyroid mental distance, Malpathy class, the neck circumference, and any red flag should prompt you to prepare this induction in a proper way. And if you feel that you are not going to be able to intubate this patient and ventilate this patient for whatever reason, if you don't feel comfortable to place this patient to sleep, do an awake fiber optic intubation. And that is a personal choice. You, as an anesthesiologist, if you feel that you cannot successfully intubate or ventilate a patient, you should go do an awake fiber optic intubation. Personally, I like to use the Yacoubian Airway when I'm doing an awake fiber optic intubation because topicalize the airway with local anesthetic, and you give the patient ample sedation, and you educate the patient on the process of the fiber optic intubation. The Yacoubian Airway allows a nice path. It prevents the patient from biting their teeth or your bronchoscope, and you can load an adult or pediatric bronchoscope with an endotracheal tube, and you can feed it through this Yacoubian Airway. And you can, once you secure the tube, you can peel this airway from around the endotracheal tube. However, if you do decide to put the patient to sleep, do optimize your patient positioning. Do have all of your tools available, like your videoscopes and your bronchoscopes. Don't wait until things fall apart until you get your airway equipment ready to go. Now, if you have a patient with a difficult intubation, you always want to, let's say you decide to place the patient to sleep, and we go back to our case, and now you are not able to perform laryngoscopy. You try to ventilate the patient, and you move on to an LMA in order to see if a supraglottic airway is going to be adequate to ventilate your patient. But meanwhile, in parallel to this, you want to trigger a code airway. If you are in this can't intubate, can't ventilate scenario, you want to be always a step ahead. You don't want to wait until you can't intubate and can't ventilate to trigger your surgical airway. You want to have your tray kit ready, your surgical team ready to go in case you fall into this scenario of a difficult laryngoscopy and possibly difficult intubation. Let's say if you place your LMA and you are able to ventilate through the LMA, you can actually very easily intubate the patient through the LMA. First of all, make sure you have all of your gels and lubricants around, and you can get an entry device which will accommodate. So this is the entry, and these are the adapters that come in the entry, and we'll talk about those in a minute. The entry device can go through a pediatric bronchoscope. I recommend that you lubricate these scopes really well, and lubricate your entry very well, and then you can pass the bronchoscope and the entry through the LMA, and that way you can actually place the entry through the LMA, and then peel the LMA off of the entry, or pull the LMA out with the entry still in place, and then you can pass an endotracheal tube, almost like it becomes like a bougie. Be aware that at any point you can lose the airway if your entry comes out of the trachea. So you have to be aware of that. And for whatever reason, if you can't pass the endotracheal tube through your entry device, remember that these adapters that come with the entry kit can actually really be helpful for providing ventilation until you get to a point where you can, secure the airway. So you have this adapter that attaches to the entry, and you can attach even a bronchoscope adapter through that, and then you can provide positive pressure ventilation through this adapter through the entry into the patient's airway. So if you, for whatever reason, hit a wall and you can't really place an endotracheal tube, you can use your entry to ventilate the patient until you find a solution. There's another adapter here that is basically like a lure lock, and this is there in order for you to be able to provide jet ventilation through the entry. So you lure lock your jet ventilator to the entry through that adapter, and you can jet through it. So you have to be aware that your pressures on your jet are not too high, because you don't want to cause pneumothorax, and you want to allow ample time for passive exhalation. So you can't intubate, can't ventilate. Always stay a step ahead. Always know where your tracheostomy kit is, and always know where are your helpers, like your surgeon or your attending or another colleague. And also, as an anesthesiologist, it is important for us to know how to provide transtracheal jet ventilation if all of the options fail, and we are the only person there to provide help for that patient, which is not a very uncommon scenario. Therefore, it is important to know how to perform a cricothyroidotomy, or how to insert an angiocath through the cricothyroid membrane. So it's important for us to identify where the cricothyroid membrane is, and it is recommended for any anesthesiologist to locate the cricothyroid membrane, especially in patients who are anticipated difficult intubation, prior to putting any patient to sleep. You can actually feel it, you can localize it. We can talk about what you can do to help you with those steps. But let's say you do place an angiocath through the patient's cricothyroid membrane and you can't intubate, can't ventilate scenario. And what do you do next? You place your angiocath. How are you going to ventilate the patient? Again, remember, you can jet through this angiocath. This is like a last minute resource, but you do have to understand like the lower lock mechanism of the jet ventilator will allow you to provide ventilation through either an entry with the adapter, a tube exchanger and adapter, or an angiocath. And you have to really understand that it's not only about getting the angiocath into the patient, it's also about understanding how do you deliver oxygen to the patient. You can also use an ultrasound in order to locate the cricothyroid membrane. And here you'll see the thyroid cartilage at the proximal end of the image. And then you have the thyroid cartilage and the cricoid cartilage. And in between, you have the cricothyroid membrane. You can locate this. And for practice, I would recommend you scan your patients regularly in order to understand how to detect the cricothyroid membrane with an ultrasound. And there are lots of videos online that are very educational on how to perform an ultrasound to locate the cricothyroid membrane. Again, know where your tracheostomy kit is, know where your trach kits are. And for just demonstration, this is not something that most anesthesiologists perform, but we do have kits to perform, even the percutaneous tracheostomies. And the reason why I have this here, because it really shows us exactly like how you get into the airway. So you have the needle. This is an open cut down into the trachea. The needle, once the needle goes in, you place a wire, then you have multiple dilators that eventually lead to placing the trachea. So obviously, placing the trach. Obviously, we're not going to be performing these procedures, but it's important for us to understand what are the steps that are required to cannulate the trachea. So predictors of difficult intubation and or predictors of difficult mass ventilation are not necessarily the same as the predictors for difficult intubation. So a lot of patients who are difficult to mass ventilate are actually easy to intubate. Therefore, if you ever find yourself in a scenario where you have difficulty ventilating, it's not unreasonable to take a look with the videoscope and to see if laryngoscopy or video laryngoscopy is easy. You can always obviously be prepared for your surgical airway meanwhile, but most of the time with these difficult ventilation scenarios, if you take a look with the video laryngoscope, you may actually find that the patient is not difficult to intubate. However, if you have a difficult ventilation and difficult intubation scenario, those are the most tricky ones. Any patient with head and neck cancer, limited jaw protrusion, patients with large neck circumference, any patient who has sleep apnea. Therefore, it is extremely important for us to ask our patients about history of snoring, history of OSA, using history of CPAP use. To me, I think that's as important as asking the patients, most, relevant or most obvious comorbidities, the fact of whether or not they use a CPAP machine. And any patient who has a high BMI is possibly difficult to intubate. If you pre-oxygenate your patient, if you take a healthy male who is pre-oxygenated to about 90% FiO2, they will desaturate to 60% in about 9 minutes, 90 seconds, in about 9.90 minutes. If you have a patient who is at 10% FiO2, they will desaturate in less than 3 minutes. So it's important to pre-oxygenate your patient. Now, speaking of oxygen, and airways and securing airways, I do want to take a moment to talk about airway fires. Every time you have a scenario where you have oxygen, flammable material, and you will create a scenario where you may have a fire. High FiO2 and BOVI and BOVI pads, all of these could lead to a scenario where you have a fire. If your patient was difficult to intubate to begin with, and now you have an airway fire, that teaching is always to pull your tube out. But again, use your common sense and do understand whether or not taking an airway out of a patient who is difficult to intubate, you may not want to like do that in some scenarios if the fire is actually controlled. Now, we'll move on to tracheal stenosis. We have had a lot of patients coming in, especially in the setting of the pandemic, who have been intubated for prolonged periods of time and who are now coming to our operating rooms with tracheal stenosis. And I really do think that tracheal stenosis is probably one of the most difficult airway emergencies to deal with. And I do think that these are airway emergencies because a lot of times we don't even know that these patients have tracheal stenosis, and then you pick that up after induction. So the fact that you can have an easy laryngoscopy or easy intubation or easy mask ventilation does not mean that you're going to avoid an airway emergency. And here is an image of a patient who has tracheal stenosis. It's a 3D reconstruction of their airway, and you can see how tight that airway is. And this is a 3D reconstruction of the bronch. And this is the way that this patient's airway looked upon bronchoscopy. Now, when I have a patient like this, if I'm seeing this patient or I'm going through this patient's records, I always try to measure the patient's airway diameter. And through the CT scan or chest X-ray, preferably CT scan, will show you what is the smallest airway diameter that the patient has. And based on that, you have to decide on what type of airway you want to place. It could be, let's say if the patient has an airway diameter of 8 millimeters, you don't want to plan on placing a 10 millimeter endotracheal tube. And it's easy. You go to any of your endotracheal tubes and you can find the outer diameter in millimeters for a certain tube. And you can compare that to the patient's airway diameter and you can come up with the proper endotracheal tube. And sometimes the proper endotracheal tube may be like a 5.0 endotracheal tube or even smaller. And we can talk about what are some things you can do in order to bypass stenotic areas like that. Now, luckily, this is an example of this patient that I showed you the 3D reconstruction of. This is a patient who came in and had a rigid bronch. So rigid bronch is a very nice way to ventilate these patients because through the rigid bronch, you could do jet ventilation and you can jet through the stenotic area and you can use the rigid bronch in order to dilate the stenotic airway. So, and then once the airway is mechanically dilated, the surgeon or the interventional pulmonologist can place a stent, and now you have a patient who comes in maybe with a 4 millimeter airway who basically extubates and has a much better time breathing after the procedure. But for us as anesthesiologists, we have to understand on how can we get this patient through this anesthetic safely. You see this patient has a very tight airway, but once you bypass the tight area, the patient's airway is normal. So you can either have a rigid bronchoscopy performed by an interventional pulmonologist, and you as the anesthesiologist can jet through that tight space. Again, being aware of all of the complications that come through jet ventilation. Or you can pass a very small endotracheal tube through that stenotic area. And again, do measure your airway and try to really do the math on what tube will be appropriate. And don't forget that the entry catheter, the tube exchanger, if you see the tube exchanger is 11 French. If you divide 11 French by 3, if you divide the French measurement by 3, it'll give you the number in millimeters. So this will be a very, very small tube. So if you don't have a very small tube present, think of your tube exchanger, your entry as tubes for ventilation, because these tubes do come, these exchange catheters and devices do come with these adapters that will allow you to either jet through or to ventilate through with positive pressure. So always keep these adapters handy and think of these as like the smallest tubes you have in your operating room. I'm always thinking of these as my backup for these really difficult scenarios. You can also use a pediatric bronchoscope to flush oxygen into the field. Now let's move on to the last topic, which is hemoptysis. You intubate a patient, and then this is what you see, an endobronchial lesion that's actively bleeding. What do? The first thing you want to do when you see a bleeding airway is to flush cold saline into the space or dilute epinephrine into the flush to vasoconstrict those bleeders in the airway. Or you have to think about tamponading the area that's bleeding. So you can inflate a Fogarty cat balloon, or you can place a blocker or double balloon tube or mainstem intubation on the side that's bleeding. And the idea is to prevent the other side from getting soiled with blood. What you don't want is for it to have blood on both sides of your lungs, on the right or the left. So if your patient's bleeding from the right side, you may want to think about inflating a balloon on the right in order to prevent the blood from the right to go into the left lung. So you now have at least one lung that you can ventilate through. So that's obviously if your ice saline and your epinephrine fails. If you have a interventional pulmonologist or a thoracic surgeon in the room, a lot of times they can do argon plasma coagulation of these bleeders, and they can achieve hemostasis through that. And again, that's a very nice way to stop these bleeders. And the beauty of the APC is that it only provides thermal energy that penetrates 2 to 3 millimeters. But it's not risk-free. You can always get airway fires with these. So you have to really understand how to use the APC, not to have endotracheal tubes that could really catch fire. You can really disrupt implantable electrical devices, and sometimes you can even get complications such as airway perforation, or less commonly gas embolisms, coronary events, or even strokes. And I think this will lead to the conclusion of our talk. And I really would like you to remember that, think of your difficult airway as one component of airway emergencies, but there's a whole wide spectrum of scenarios that happen in the operating room where you have a secure airway that all of a sudden leads to an event of either losing the airway or the saturation event, or you may see surprises distal to your vocal cords that may prompt you to use your expertise to save the patient. And thank you for joining.